Good evening, guys. How are you doing? We'll start with the first question. So, a 55-year-old patient under anesthesia is receiving vecuronium. You apply a nerve stimulator and find only one twitch visible in train of force stimulation. What does this indicate? So, guys, this is regarding the train of force stimulation. So, look over here. So, guys, remember, for neuromuscular blockade effect, what we do is, to assess the neuromuscular monitoring, we go for many things. That one is train of force, other is tetanic stimulation, other is post-tetanic stimulation. The most commonly used one is train of force. In train of force, guys, what we do is we give 4 twitches. Just look over here. Before solving the MCQ, we'll give 4 twitches. Just look over here. This is my hand, and I apply the train of force electrodes, and I give 4 twitches. Just look over here. 1, 2, 3, 4 twitches. All 4 twitches response will be the same. Okay, I am not under muscle relaxant activity. If I received a non-depolarizing muscle relaxant, just look over here, what will happen? After giving non-depolarizing muscle relaxant, after 2 to 3 minutes or 3 to 5 minutes, I apply the train of force and I give 4 twitches. 1, 2, 3, and the 4th twitch is gone. If 4th twitch is gone, that means what? That means 75% of the receptors are blocked. If 4th twitch is gone, that means 75% of the receptors are blocked. Okay. Now, after like more 2 minutes, I give more 4 stimulations. 1, 2. Yani now I just get 2 twitches. 2 twitches are gone. If 2 twitches are gone, that means 85% of the receptors are blocked. Yani if the 3rd twitch is gone, that means 85% of receptors are blocked. Whereas, if at all, while stimulating, if I get only 1 twitch, okay, only 1 twitch, all other 3 twitches are gone. If 3 twitches are gone, that means 95% of the receptors are blocked. If only 1 twitch is seen, that means 95% of receptors are blocked. Okay. If at all, after giving non-depolarizing muscle relaxant, you give train of force and you see no twitch, that means patient is in deep neuromuscular blockade. Okay. So guys, remember we are discussing about train of force. In train of force, if 3rd twitch is gone, that means 85% of receptors are blocked. If 2nd twitch is gone, that means 95% of the receptors are blocked. And if 1st twitch is gone, that means total 100% of receptors are blocked. Now, after giving train of force, you will take 2 things. You will look for train of force ratio and you will look for train of force count, TOF count. Okay? TOF count is different, TOF ratio is different. The 95% receptor block, these receptors block, these are train of force count. Train of force ratio is different for different muscle relaxants. Now, what is train of force ratio? First of all, you need to understand, guys, this is the train of force monitor that we use. And what is the nerve that we use for train of force monitoring? The most commonly used nerve is the ulnar nerve, and the muscle that is being used for train of force monitoring is adductor pollicis longus. Adductor pollicis, that is the muscle, right? So now in train of force, you need to remember there is train of force ratio and train of force count. Now we have just discussed about the train of force count. Coming to train of force ratio, what is train of force ratio? Train of force ratio is basically if you give a depolarizing muscle relaxant. Imagine I have been given succinylcholine. After receiving succinylcholine, if someone gives me 4 twitches, remember what happens? Succinylcholine has been given to me and 4 twitches are given. Just look over here. First response will be like this, second like this, third like this, fourth like this. Yani ke basically you are seeing all 4 twitches. After 5 minutes, again you check. What you will see, first twitch like this, second like this, third like this, fourth like this. Yani ke basically what are you seeing over here is what you are seeing, that the twitch response is decreased. Twitch response is decreased. So, but remember, twitch response is decreased, but it is decreased at the equal amplitude. It is not fading. Remember, in depolarizing muscle relaxant, when you take a train of force ratio, that is train of force T4 to T1, yani ke 4 twitch to first twitch, what is the ratio that you get? Ratio that you get is 1. Okay. Whereas for non-depolarizing muscle relaxant, guys, for non-depolarizing muscle relaxant, what is the twitch, what is the ratio that you see? Just look over here. In non-depolarizing, when someone has given me vecuronium and then 4 twitches are given. After 5 minutes, you will see first twitch, second twitch, third twitch, and fourth twitch response is decreased. Okay, so remember, in non-depolarizing muscle relaxant use, what you will see, T1 will be more, T2 will be like same, like similar to T1, T3 is also similar to T1, but T4 is reduced. So you will see a faded response. Okay, T1 will be like this, T2 will be like this, T3 will be like this, and T4 will be faded. That is called as a faded response. And a good a good blockade requires a train of 4 ratio of less than 0.4. Usually in non-depolarizing, you will see this ratio of 0.4. In depolarizing, all twitch heights are equally reduced. Equally, they are reduced. Okay, so it will be 1. For reversal, how much of it is required, guys? Yani ke after surgery is done, now you need to reverse the patient. The train of 4 ratio should be more than 0.9. Okay, so remember, the first twitch to disappear is T4 and the last twitch to reappear is T1. Okay, guys, something about monitoring in anesthesia. Everyone just look over here. When we are discussing about monitoring, basically this MCQ was regarding the monitoring in anesthesia. So when we are discussing about monitoring, what are the things that we monitor? We monitor the oxygenation of the patient by pulse oximetry. Pulse oximetry. Okay, this pulse oximetry usually works on the Beer-Lambert's law. Beer-Lambert's law. Second, you monitor the patient's ventilation. How will you monitor the patient's ventilation? With the help of capnography. Okay. Third, you monitor the patient's circulation. How is the circulation of the patient monitored? Circulation of the patient is monitored by BP, ECG, and transesophageal echocardiography. In the BP, there are two types, guys, invasive and non-invasive. For invasive, we use what artery? We use radial artery, guys. And if you want to know the patency of radial artery, then you can go for Allen's test. Allen's test. Okay. ECG monitoring. In ECG, not all 12 leads, only 2 leads are important. Lead 2 and lead 5. Lead 2 detects arrhythmias, whereas lead 5 detects ischemia. Lead 5 detects ischemia. Okay. Next, TEE. TEE is what? Transesophageal echocardiography. This transesophageal echocardiography is basically important for detecting venous air embolism. Not all surgeries, but for venous air embolism. Apart from that, what else you monitor, guys? You monitor for the temperature. In temperature, you are having core temperature and peripheral temperature. For core temperature monitoring also, there are some sites, guys. What are the sites for core temperature monitoring? You monitor at the lower end of the esophagus and the pulmonary artery. But which is the most commonly used, guys? It is the esophagus. Okay, which is the most accurate in core temperature monitoring? It is the pulmonary artery. Why? Because pulmonary artery is an invasive thing. Okay. Next is awareness. Awareness you monitor by what? Awareness you monitor by bispectral index, BIS monitoring, okay, which calculates the sum of EEGs. And neuromuscular monitor we have already discussed. Okay, coming to the second MCQ, guys. Pulmonary artery gives you the most accurate, guys. Ideal site is esophagus. Why? Because in esophagus, you just keep the probe. Is it invading? Is it invading through and through the esophagus? No. Okay. But pulmonary artery is invasive thing. Okay. Next. During laparoscopic surgery, there is sudden rise in airway pressure and fall in saturation. Capnography shows a sudden drop in EtCO2. Which complication is most likely? Okay, so A, malignant hyperthermia, B, gas embolism, C, bronchospasm, and D. First of all, guys, you need to remember, during laparoscopic surgery, if the patient is having sudden fall of EtCO2 and fall of saturation. Remember, airway pressures can be raised during laparoscopy due to n number of reasons. There are many reasons, guys. They are the endotracheal tube, they are the tubes could be cause of the airway pressure high, or the patient having bronchospasm, airway pressure might be high. But here, over here, what he's telling, fall in saturation with fall of EtCO2. Two options I can easily rule out. What two options I can easily rule out, guys? Two options that I can easily rule out are option D and option A. Why? Because remember, in malignant hyperthermia, what will you see into the EtCO2? You will see that EtCO2 in malignant hyperthermia is high. So this can be ruled out. Second, if the soda lime is exhausted, then what you will see? You will see the EtCO2 rising above the baseline. So So in these two cases, EtCO2 is high. These two are ruled out. What are the two other options which are left out with bronchospasm and gas embolism? Again, guys, bronchospasm can't be the answer. Why? Because in bronchospasm, yes, airway pressures are high, but what will happen to the capnography? Capnography, you won't see a sudden drop in EtCO2. You will see a shark fin capnography. You will see a shark fin capnography. And apart from shark fin capnography, you will see a rise in EtCO2. Rise in EtCO2. But if it is complete bronchospasm, then you will see fall in EtCO2. So these three options are ruled out. What are we left out with? Gas embolism. Always remember, guys, sudden fall in EtCO2, it should be gas embolism. If not gas embolism, then it could be what, guys? It could be accidental extubation. Tube is out, suddenly you will see fall in EtCO2. Okay. Now, regarding the EtCO2, guys, we need to remember a few things. EtCO2, there are four phases, guys. Okay. You can see this EtCO2 graph. In EtCO2 graph, there is phase 1, phase 2, phase 3 and phase 4. This phase 1 is called as what? It is called as inspiratory baseline. Inspiratory baseline. Phase 2 is called as expiratory upstroke. Phase 3 is called as alveolar plateau. Alveolar plateau. And phase 0 is called as inspiratory downstroke. Inspiratory downstroke. Between phase 2 and phase 3, there is an angle which is called as alpha. Between phase 3 and phase 0, there is an angle called as beta. This beta angle is very important, guys. Why it is very important? Why? Because EtCO2 is measured at this angle. And EtCO2 is a confirmatory test for what? If you have intubated the patient, then if you want to confirm that your tube is in the trachea, the best way to confirm is by EtCO2. What is the normal value of EtCO2, guys? 35 to 45 mm of Hg. We'll also see some of the EtCO2 graphs, guys. Okay? If you see after intubation, if you see a flat capnograph, straight line, what does it indicate, guys? Yani you have intubated, but you get a flat capnograph. It indicates you are in the esophagus, or the patient might have cardiac arrest. After intubation, the patient had cardiac arrest. Or accidental intubation also, you will see a flat capnograph or sudden fall on EtCO2. Okay. Second, EtCO2, if the capnograph appears like shark fin. Shark fin capnography is commonly seen when a patient is having bronchospasm. But again, EtCO2 value over here is what, guys? It is basically normal to high. It does not decrease unless and until it is a complete bronchospasm. Complete bronchospasm, EtCO2 will be gone. Okay. Next, guys. Step-ladder capnography, I have already shown you. Step-ladder capnography is seen in a condition called as malignant hyperthermia. Malignant hyperthermia. Step-ladder capnography. Fourth EtCO2 is what? EtCO2 above the baseline. Come on, guys. EtCO2 above the baseline means what? It is not starting from the bottom. It is starting above the baseline. It is seen in which condition? It is seen when the patient is inhaling his own carbon dioxide, such as exhausted soda lime, or it could be seen in case of faulty expiratory valve. Okay. Next, guys, sudden fall in EtCO2. We have already discussed sudden fall in EtCO2 is seen in venous air embolism. Come on, guys, in venous air embolism, what is the murmur that you see? Please tell me the murmur, then we'll move forward. What is the murmur called in venous air embolism? MW murmur. Mill wheel murmur. Okay. Next is, guys. Next, in the EtCO2, if you see development of Currar notch, what does it indicate, guys? Currar notch indicates that the patient is started rebreathing. In cases of rebreathing, yani कि patient has been spontaneously breathing, you will see development of Currar notch. Okay. Last, guys, let's look over here. In hyperventilation, if at all you are ventilating or keeping the respiratory rate too high, then carbon dioxide will be washed out. Due to that, EtCO2 level will be appearing like this. In case of hyperventilation, as the carbon dioxide is being washed off, you will see this kind of EtCO2. Whereas in hypoventilation, what kind of EtCO2 you will see? In hypoventilation, as you are ventilating very less, EtCO2 rises like this. Okay, EtCO2 rises like this. Okay, that is in hypoventilation. Hypoventilation. Okay, now coming to the third question, guys. Before going to the third question, a 45-year-old man is undergoing laparoscopic surgery under general anesthesia. The anesthetist is using BIS monitoring to titrate the depth of anesthesia during surgery. The BIS value is noted as 85 while the patient is receiving sevoflurane. Which of the following is the best interpretation? So guys, just look over here. BIS is what? BIS basically indicates what does it indicate? BIS indicates that the patient is aware or not during anesthesia, right? The BIS values, guys, remember BIS values are nothing but the sum of EEGs. The values will be coming like 100 or values will be coming like 40. Okay? Remember two extreme values first. One is 100, other is 40. 100 means patient is fully awake. 40 means what? Patient is too deep. If you remember 140, just we have to remember the middle values. The middle values would be what, guys? If it is between 40 to 65, that means this BIS value is adequate for anesthesia. Okay? It is adequate depth of anesthesia is received. Okay, 40 to 65. If the BIS value is between 60 to 85, that means the patient is light or patient might be awake. Okay, so this is called as a sedation BIS. Sedation BIS. Okay, so normally for surgeries we require adequate depth of anesthesia. The BIS value should be 40 to 65. Over here, 85 value is given. What does 85 indicate, guys? 85 indicate patient may be awake or there is a lighter anesthesia. Remember, BIS was given for what? Patients who were aware during anesthesia. There were many patients who told that after surgery, sir, I was able to hear your words. I was able to hear what you guys were talking. It made me anxious. Okay, this can be happened. This can easily happen, guys. When your inhalational agent that you are using to maintain anesthesia, when it is not working properly, it can happen. Okay. Now coming to the fourth question, guys. During induction, a 50-year-old patient with rheumatoid arthritis develops cannot intubate, cannot ventilate kind of scenario after a failed laryngoscopy and supraglottic airway placement. What is the next step? Come on, bhai log. What is the next step? Cannot intubate, cannot ventilate kind of scenario. Come on, what's the answer? A, B, C, D. Now first we'll rule out the wrong options. Just look over here. Try repeated laryngoscopy with a wrong tube, with a smaller tube. Why it can't be the answer, guys? Remember, in the question he has already told you cannot intubate, cannot ventilate. Yani ke basically in the DAS guidelines, when do you give cannot intubate, cannot ventilate? When plan C has failed. Already plan A, plan B, plan C, you did it. Now directly he is asking what is plan D. Whenever cannot intubate, cannot ventilate means what? You have to go for cricothyrotomy. Now look over here. You cannot go for a repeated laryngoscopy because already you have done laryngoscopy. Can you go for bag mask ventilation? No, you cannot go for bag mask ventilation also. Already it has been declared you are not able to ventilate the patient. Can you wait for the patient to wake up? No, you are not able to ventilate. Patient will die if you are not able to ventilate. If you wake up for the if you wait for the time so that the patient wakes up, he will die because you are not able to ventilate. Now look over here, guys. There are 4 steps for difficult airway, which we have already discussed. The first is what, guys? Remember, first is I try for normal laryngoscopy. Just look over here. I try for plan A, that is a normal laryngoscopy. I put the laryngoscope, I try to intubate, but I fail in intubating. One plan A is failed, then I'll go for what, guys? I'll go for plan B. Plan B is what? I'll go for LMA insertion. What is LMA? Laryngeal mask airway. I'll put a LMA. Remember, guys, if I am failing in plan A, if I am failing to intubate, our second aim should be what? At least I should ventilate my patient. That should be a whole aim. How should you ventilate? Plan B is what? By supraglottic airway, that is LMA. After putting an LMA, 90% of the time you will ventilate. But if at all you fail in plan B, then you go for plan C. Plan C is what? You ventilate the patient. Again, in plan C also, your aim is ventilating the patient with 2% technique. One person will be holding the mask, other person will be bagging. 2% technique. But if plan C also fails, then you go for plan D. That is what? That is you go for either needle cricothyrotomy or either scalpel cricothyrotomy. Needle cricothyrotomy is a temporary measure where you are inserting a needle, where you insert a cannula and you give transtracheal jet ventilation. Okay? But that is a temporary measure, guys. Temporary measure means after 20 to 30 minutes, you have to go, or within 20 to 30 minutes, you have to go for surgical cricothyrotomy or tracheostomy. Okay. So remember over here, what are we discussing? What is the answer over here, guys? B is the right answer. Transtracheal jet ventilation. How can bagging fail? Now look over here. Yes, bagging can fail. Now what can happen is, I'll tell you how it can fail. Look over here. In plan C, what we did. In plan B, I had, in plan A, I tried to intubate. I did not. Okay, plan B, I put an LMA. While putting an LMA, I try to manipulate the airway in such a manner that patient develops laryngospasm. By normally, not all patient, but 50% of the patient will develop laryngospasm due to the tracheal intubation attempt and also LMA insertion. That's why in 50% of the cases, plan C fails to intubate, fails to ventilate by bag and mask. In that scenario, you have to go for plan D. Okay. What is this picture which is given over here? What is this tube picture? Come on, be fast. It is the tracheostomy tube. Okay. It is a tracheostomy tube. Recently, a question was asked, I guess, regarding the difficult airway thing. Cricothyrotomy, is it temporary or permanent? Remember, guys, needle cricothyrotomy is a temporary measure. Scalpel cricothyrotomy is a permanent kind of measure. Permanent means definitive. Okay. Next. Now, regarding airway, what else we need to remember is we also need to remember some of the things of airway. That is the narrowest portion of airway in adult and narrowest portion of airway in child. In adult, it is the glottic opening, and in the child, it is the subglottic. Okay, subglottic. Now, we also need to remember how do you intubate the patient. For remembering how do you intubate the patient, first we need to go for the positioning. In which position we need to keep the patient, guys, for intubation? It is the sniffing morning air posture. Sniffing morning air posture is what, guys? There is flexion at the cervical spine and extension at the atlanto-occipital joint. Flexion at the cervical spine and extension at atlanto-occipital joint. After giving this position, I'll take an instrument which is called as laryngoscope. This laryngoscope will have two blades, guys. One is a straight blade which is called as Miller's laryngoscope, commonly used in pediatrics. Why? Because we have to lift the epiglottis. They are having a large epiglottis which could be lifted by Miller's. And other is the curved blade laryngoscope which is called as Macintosh laryngoscope. Okay? You introduce the laryngoscope, you lift the tongue and you will see now the vocal cords. Now, based on the appearance of vocal cords, there are four types, guys. What are the four? This classification is called as what? This classification is called as Cormack-Lehan's classification. Cormack-Lehan classification. Okay, in Cormack-Lehan, basically, I'll put the laryngoscope, I lift the tongue, and I'll see grade 1. When do you say grade 1 laryngoscope? When do you see grade 1 laryngoscope? Grade 1 laryngoscope means what? The laryngeal aperture is wholly visible. Grade 2 Cormack-Lehan is called as what? It is basically the posterior laryngeal aperture. Posterior wall of laryngeal aperture is visible. Grade 3 means what? Only epiglottis is visible to you. And grade 4 means what? Epiglottis is also not visible. Epiglottis is also not visible. Okay. So that is Cormack-Lehan grading. Right. Now, after lifting this, next you have to put the tube. Now, guys, while putting the tube, which tube are we using? There are two kinds of tube. Previously, we are used to have one tube which is called as red rubber tube, but we are not using this red rubber tube. Why? Because remember, guys, best way to secure the airway is by endotracheal tube. Previously, we were using red rubber tube, but this red rubber tube was having what? Look at the cuff size, guys. It was causing high pressure. So basically, red rubber tube was high pressure, low volume. Hence, it was causing tracheal mucosal injury. Tracheal mucosal injury. Hence, we are not using this tube, guys. We are using what? We are using the tubes which are made up of PVC. PVC tubes are what? PVC tubes are low pressure, high volume. Low pressure, high volume cuff. And once you put the endotracheal tube, how will you confirm, guys? the surest way to confirm the position of the surest way to confirm endotracheal intubation is done in the trachea is by capnography, that is ETCO2. ETCO2. Coming to the next question, guys. A 30-year-old patient, polytrauma patient with facial fractures and bleeding oral cavity requires urgent intubation. Which is preferred airway device? Come on, guys, what's the answer for it? A, B, C, D, come on. So, polytrauma patient with multiple facial fractures and bleeding oral cavity requires urgent intubation. Which should be done? Surgical tracheostomy under local. Guys, this should not be done. Why? Because 30-year-old patient is there. He requires intubation, urgent intubation. I'm totally agreeing with this point. Okay? Definitive will be this one only. Definitive thing would be this one. But the most preferred, first, in cases of polytrauma where patient is having oral cavity bleeding, if you want to secure the airway, first put the tube, endotracheal tube inside the trachea. Don't directly go for tracheostomy. Okay? Tracheostomy could be definite, but again, before going to tracheostomy, you are still having an option. Now tracheostomy is ruled out. Now guys, look over here. What are we left out with? Supraglottic LMA. Remember, this cannot be done, guys. LMA is usually avoided if the patient is having blood in the oral cavity. If there is blood in the oral cavity, you put an LMA, that clot of blood will go into the trachea and the patient will land up into aspiration. So LMA cannot be done. Now you are left out with two options: fiber optic bronchoscope and laryngoscope, video laryngoscope. First, I'll show you what is fiber optic bronchoscope. Just look over here, guys. The device which I am holding in my hand. Okay? This is a fiber optic scope. Look at the tip, guys. Look at the tip of the scope. This tip I am bending. Okay? This is fiber optic bronchoscope. Now look over here. Should I use that device or should I use video laryngoscope? If I use a fiber optic scope means what? I am putting that stick into the patient's mouth, oral cavity, and when I put this, what will happen? The fiber optic scope will have a camera on it. That camera will, when I put it into the patient's mouth, he's having blood in the oral cavity. The vision is gone. The vision is gone by it. I cannot clean the camera. For cleaning the camera, again I need to pull it out and again clean it. So fiber optic bronchoscope is not the preferred one. Which one is preferred, guys? Video laryngoscope. Video laryngoscope, just look over here. Video laryngoscope is what? Just look over here, guys. This device is video laryngoscope. Now I'll show you. There was a patient who came with polytrauma and I did a video laryngoscope. Now once I introduced a video laryngoscope was into the patient's mouth. I was looking at the screen. The patient was having blood. So what I did, I took the suction and I have cleared the blood. Clot was there, I have cleared. But still I was having a very good view. Then after suctioning, I got this view. Just you can look over here, guys. With video laryngoscope, I was getting this view. I was seeing the vocal cords and I intubated. So guys, which is the right answer over here? Come on, which is the right answer? Video laryngoscope. Video laryngoscope. I hope everyone got it. Why fiber optic is not used. Surgical tracheostomy is the definitive. If video laryngoscope fails, you have to go for surgical tracheostomy. Okay. Now, remember LMA. Regarding LMA, I told you LMA should not be put. Why? Because LMAs are contraindicated if the patient is having blood in the oral cavity. Now, regarding LMAs, guys, are LMAs regarded as a definitive airway? No. LMAs are non-definitive airway. Okay, we'll discuss something about LMAs. LMAs are non-definitive airway. They are first generation, second generation, and they are some special type of LMA. First generation means what? Only one port is there. Only tracheal port through which you can ventilate. What are the examples of first generation LMA? You are having classical LMA. You are having flexometallic LMA. You are having Cobra LMA, and you are having Ambu Aura 40. These all LMAs are having a single port. Okay. Second generation means one more additional port was added through which Ryle's tube was passed so that gastric deflation was easily done. Extra port means second generation. Second generation examples are LMA Procil, okay? LMA Supreme, okay? LMA iGel. iGel is also LMA, guys. Then Slippa is there, streamliner of pharynx, and Ambu Gain. Remember, Ambu Aura was the first generation LMA. Ambu Gain is the second generation LMA. All these LMAs are having a second port through which you can put the Ryle's tube and deflate the stomach. Other special type of LMA is intubating LMA. You are also having an intubating LMA. Okay. Next, guys, question number 6. A 60-year-old COPD patient is on pressure controlled ventilation. He develops sudden hypotension after PEEP is increased from 5 to 12 centimeters of water. Okay. What is the most likely cause? A, B, C, D. Now over here, patient has COPD, okay, and he develops hypotension, right? Once the PEEP is increased from 5 to 12 centimeters. Now look over here, guys. They are asking about PEEP is increased. Most of you are answering that airway resistance. The answer is wrong, guys. Airway resistance will not cause hypotension. If airway resistance is increased, it will increase the airway pressures. It will increase the airway pressures. It won't cause hypotension. It will increase the airway pressures. Okay? Next, myocardial infarction. Myocardial infarction cannot be the answer over here. Remember, myocardial infarction, even though during anesthesia it can also happen, but myocardial infarction ke liye, in the question he should mention something about the ECG, something about chest pain or something. Okay, myocardial infarction could not be the answer over here, right? Next, what are you left out with? You're left out with A and D. Ventricular asynchrony. Yes, ventricular asynchrony can also be a cause of increase in the airway pressure, but again, it does not cause sudden hypotension. It will cause slight hypotension. It will cause very slight hypotension. Again, these three are ruled out. Now remember, guys, question is simple, straightforward. When you are applying PEEP, PEEP is nothing but positive end expiratory pressure. When the pressure is increased, normal PEEP is between 5 to 8, but you have increased to 12. What will happen? It will increase the intrathoracic pressure, that will decrease the venous return, and when the venous return is decreased, cardiac output decreases, and hence the BP decreases. So basically the answer over here is what, guys? It is A, reduced venous return. When you increase the PEEP, intrathoracic pressure increases. Remember, guys, due to this reason, as you are increasing the PEEP and all, due to this reason that PEEP will decrease BP, due to this reason, PEEP is contraindicated in patients who are in shock. When a patient is in shock, you never give positive end expiratory pressure, right? Now, guys, we need to first understand what is PEEP. PEEP is nothing but positive end expiratory pressure. Normally, if the patient is having ARDS and much of the alveoli are damaged, what we do? We give this PEEP. When we give this PEEP to the patient, what will it do? It will recruit newer alveoli, or it will recruit some new alveoli, which will help to improve oxygenation. So look over here, guys. What is PEEP doing? PEEP recruits the newer alveoli, which will help for oxygenation. So as it is recruiting the new alveoli, what will happen to the oxygenation? The oxygenation of the patient improves. Okay? What will happen to the work of breathing, guys? The work of breathing reduces. Okay? Work of breathing reduces. What will happen to the atelectasis, guys? It will reduce atelectasis. It will reduce atelectasis. But at the same time, what is PEEP also doing? PEEP increases the intrathoracic pressure, that leads to reduced venous return, that leads to hypotension. So look over here, guys. PEEP improves oxygenation, prevents atelectasis, and decreases the work of breathing. Normally, we used PEEP in cases of ARDS and pulmonary edema. But what is the side effect of PEEP, guys? The side effect of PEEP is patient whose side effect of PEEP is it will decrease the BP, hence contraindicated in shock, as well as PEEP will also decrease the cerebral venous drainage. Cerebral venous drainage. If cerebral venous drainage is decreased, guys, what will happen to the intracranial pressure? What will happen to the intracranial pressure? Be fast. Intracranial pressure increases. That is why PEEP is also contraindicated if the patient is having any head injury. Okay? Head injury. So this is regarding what, guys? This is regarding the positive end expiratory pressure. Come on, guys. Coming to the next question. Is PEEP clear? Right. A patient with neuromuscular weakness on SIMV mode, which of the following best describes the SIMV? SIMV is nothing but synchronized intermediate mandatory ventilation. Okay. So look over here, guys. In SIMV, what is the answer, guys? Remember, SIMV, first we'll rule out the options. All breaths are mandatory. Volume is preset. That is totally wrong. Volume is preset. No. Volume is preset in volume control. Okay. Only pressure support. No. Only pressure support is given in pressure support mode. Spontaneous breathing is allowed in SIMV. So these three are ruled out. What is the answer? SIMV means you allow the patient to spontaneously breathe in between the breaths given by ventilator. That is called as SIMV mode. Okay. Now guys, look over here. When we are discussing about SIMV mode, first we'll discuss something about ventilators. Ventilators are of two types, guys. One is called as non-invasive, other is called as invasive. If a person is suffering with COPD, then you can go for non-invasive ventilator. Okay? Remember, non-invasive ventilator, I'm not telling that all COPD patients of non-invasive ventilator, all COPD patients should be on non-invasive ventilator. No. COPD patient who's conscious and empty stomach and having respiratory distress, yani कि vital prerequisites for non-invasive is what? Patient should be conscious, okay? Empty stomach. Then you need to put the patient on non-invasive. In non-invasive, there are two types of mode. One is called as CPAP, other is called as BiPAP. CPAP and BiPAP. Continuous positive airway pressure, usually given for milder COPD, and BiPAP is what, guys? BiPAP means basically two pressures are given. Inspiratory pressure as well as expiratory pressure. Higher inspiratory and lower expiratory pressure. BiPAP is usually given for severe kind of COPD. Okay, that's regarding the non-invasive modes of ventilator. Okay, now going to the invasive modes of ventilator. But before going to the invasive mode of ventilator, guys, I'll just give you a picture. You guys tell me which mode of ventilator will say this. कभी कभी लगता है अपुनी भगवान है, यानी कि basically it is one ventilator mode that will be telling this, which is controlling all the things, controlling the volume as well as the pressure. What is that mode? Remember, I'll give you the options. There is CMV mode, there is ACMV mode, there is SIMV mode, there is pressure support mode. In these, which mode will tell this? CMV mode will tell this. CMV is what? Continuous mandatory ventilation. Why? Because tidal volume as well as the pressure, both are controlled by the ventilator. Both are controlled by the ventilator. So guys, now we'll discuss something about the modes of ventilator. Okay. CMV mode, what is the control? Remember, this is the mode. This is CV means nothing but control variable. Triggered breathing is there. Sedation required or not, and then side effects. Just look over here. In CMV mode, what is the control variable? Nothing. Basically, the ventilator is controlling the tidal volume as well as the pressure. Is trigger breathing allowed in CMV mode? No trigger breathing is allowed in the CMV mode. The ventilator is the big boss controlling all the things, but the ventilator will tell to the doctor that I require the patient to be fully sedated. Okay? So ventilator will tell the patient that patient needs to be sedated. You will give patient heavy sedation. As you are giving the patient heavy sedation and keeping on CMV mode, now the patient will also become lazy. Lazy means what? He will totally become dependent on the ventilator. He will basically tell his muscles that please don't work. Ventilator is working for me. For this reason, what will happen to the muscles, respiratory muscles of the patient? Patient's respiratory muscles will develop atrophy. There is atrophy of the muscle. So that is regarding which mode, guys? That is regarding the CMV mode of ventilator. Next is ACMV. ACMV is the most commonly used mode for ventilation. Okay? In ACMV, you are having volume control and you are having pressure control. In volume control, what is the controlled variable, guys? In volume control, the control variable is tidal volume. You are setting the tidal volume. Are you allowing triggered breath? Yes. Yes, I got it. But again, for fitted, I think it's not that much problematic. I'll just tell. It is volume control and pressure control. Okay. Triggered breathing. Is triggered breathing allowed in volume control, guys? Yes, triggered breathing is allowed. ACMV means what? Assist control. If patient is behaving well on CMV, you go for ACMV. You allow the patient to breathe somewhat. Okay. How is the sedation over here? Sedation is moderate. Sedation is moderate. So in volume control, guys, what is the side effect? Now, in volume control, as you are controlling the volume, what will happen? Normally, volume control is used when the patient is having normal lung mechanics. Normal lung mechanics means patient is posted for some surgery for some other reason. His lungs are normal, you go for volume control. But you are setting the volume and you are allowing the patient triggered breathing. Due to this, what will happen? Just look over here. You are giving a breath to the patient. Now look over here. Ventilator is also, sorry, patient is also, you are giving a breath to the patient. Patient is also taking a breath. Then again you are giving a breath, and then again patient is also taking a breath. Due to that, what is happening, guys? Asynchrony. Due to the asynchrony, patient will develop what? Patient will develop hyperventilation. The respiratory rate increases. One breath is given by you, one is taken by the patient. Respiratory rate increases. If respiratory rate increases, respiratory alkalosis happens. So remember, guys, volume control is the only mode where the patient is at risk of developing respiratory alkalosis. Rest all modes of the ventilator, patient will develop respiratory acidosis only. Okay. Pressure control. What is a control variable in pressure control, guys? In pressure control mode, control variable means what I am controlling in the ventilator. I will control the pressure. I will set the pressure. Okay? And the volume keeps on changing. Trigger breathing is also allowed over here. And here also you required some moderate sedation. Moderate sedation is required over here. Okay. Now this mode is commonly used for what? For ARDS patient. But commonly, the most common side effect with this kind of mode is what, guys? Remember, as you are setting the pressure, okay? Patient, you are setting the pressure on the ventilator. Patient, the tidal volume is depending on the patient only. Okay? If the patient is having ARDS and all, what will happen to him? Well, not ARDS, basically. You are basically setting a pressure, guys, and you're not, patient is generating the volume. Sometimes in some patients, the volume generated is not that sufficient to meet the patient's FiO2. So what will happen to that patient? Patient will be hypoventilated. Due to that, patient develops respiratory acidosis. So in pressure support, in pressure control, patient will be at risk of developing respiratory acidosis. Okay. Coming to the last mode of ventilator, which is called a spontaneous mode, in which you are having SIMV mode and pressure support mode. SIMV and pressure support modes are what? These are usually the weaning modes of ventilator. Weaning modes of ventilator meaning what? Ventilator is giving one breath, and then patient is taking 2 or 3 breaths. Then again ventilator is giving, just ventilator is supporting the patient's breath. Okay. Once again, just look over here, guys. ACMV, there are 2 types. There is volume control and pressure control. Volume control means I am controlling the tidal volume. I am setting the tidal volume, and basically the pressure is adjusted according to the pressure. Patient is taking the care, patient is taking care of the pressure in volume control. Okay. Now in volume control, what could happen? As we are allowing some triggered breath, the patient might develop increase in the respiratory rate that can lead to respiratory alkalosis. Whereas in pressure control, I am setting the pressure. Okay, patient's volume might be changing. If the volume is changing, guys, what will happen? Sometimes the volume might not be adequate to to increase the saturation. Due to that, what will happen? Patient will be hypoventilated and develops respiratory acidosis. Okay, SIMV and pressure support modes are what? These are weaning modes of ventilator. In SIMV and pressure support also, what we do is, what will happen is, guys, what is the side effect? The patient, as we are allowing the patient's breath too much, basically we are giving 1 breath and we are allowing 2 to 3 breaths from the patient. Okay? And this 2 to 3 breaths of the patient might not be that adequate to reach the volume. So that will also lead to what? Hypoventilation, which leads to respiratory acidosis. Respiratory acidosis. Okay? So that's regarding what, guys? That's regarding the modes of ventilator. Come on, guys. Next is a patient with head injury is on mechanical ventilator. He's having a target PaCO2 of, we are targeting a PaCO2 of 30 to 35 mm of Hg for ICP control. Which ventilator adjustment is most appropriate? Come on, guys. Now look over here. If I increase the FiO2 over here, will it decrease the PaCO2? No. If I increase the FiO2 also, it will not decrease the PaCO2. Increasing FiO2 won't help. Okay? If I increase the PEEP over here, what will it do? I told you, if I increase the positive end expiratory pressure, it will decrease the cerebral venous drainage. And if cerebral venous drainage is decreased, it will further increase the ICP. So this cannot be done. Can you go for decreasing the tidal volume? No, sir. If I decrease the tidal volume, invariably it will increase the ICP. So what we need to do, guys, any patient who's suffering with any head injury, normally we go for hyperventilation. We increase the tidal volume or we either increase the respiratory rate. In turn, we are basically increasing the minute ventilation. Minute ventilation is nothing but tidal volume into respiratory rate. If you increase the minute ventilation, what will happen? That will decrease the intracranial pressure. Okay. Now, we have to remember some values, guys, while setting. Now, look over here. First is RR. RR is what? Respiratory rate. When you are setting a respiratory rate, how much should be the respiratory rate, guys? Normal respiratory rate should be how much? PaCO2, I am telling, guys. PaCO2. So look over here, guys. What is the normal respiratory rate that we set? 12 to 18. 12 to 18. Okay. But if the patient is having respiratory acidosis, guys, how much should be the respiratory rate that should be set? It should be always increase. If the patient is having respiratory acidosis, you should increase the respiratory rate. Tidal volume, how much should be set, guys? Tidal volume should be set as 6 to 8 ml per kg of body weight. But if the patient is having ARDS, then what should we do to the tidal volume? We should reduce the tidal volume to 4 to 6 ml per kg body weight, or also less than that, because it's a lung protective strategy. FiO2, what is the minimum FiO2 that we keep in the patient? It is 21 to 100%. Depending upon the patient's condition. Next is PEEP, guys. PEEP, how much you should keep? 5 to 8 of PEEP you should keep. But maximum of PEEP can be kept up to 24 also, depending upon the on FiO2 and depending upon for which condition are we using ventilator. Okay, 5 to 8. Next, PPLAT. PPLAT pressure should be how much, guys? It should be less than 25 to 30 basically. Next, inspiratory to expiratory ratio. It should be 1:2 or 1:3. 1 inspiration is to 3 expiration. But in cases of ARDS, we will go for a reverse ratio or inverse ratio ventilation. That is, we keep 3 inspiratory to 1 expiratory, or 2 inspiratory to 1 expiratory ratio. Okay. Guys, these are the normal values. And in cases of conditions, what I have done, I have written over here. In respiratory acidosis, I will increase the respiratory rate. Okay. ARDS, hypoxia and all, we have already discussed. Okay. During general anesthesia, an intern accidentally connects a blue cylinder instead of white shoulder black cylinder to the yoke. The patient develops desaturation only after induction, shortly after induction. What was the gas most likely to be connected by mistake? Come on, guys. Basically, we ordered for what cylinder? We ordered for black body, white shoulder cylinder, that is oxygen cylinder. But the intern connected a blue cylinder. Blue cylinder is what, guys? Blue cylinder is nitrous cylinder. Okay, nitrous cylinder. So he is talking about nitrous cylinder. So as we are talking about nitrous cylinder, guys, remember carbon dioxide cylinder, what is the color, guys? Gray color. Air cylinder is what? White body and black shoulders. Helium cylinder is brown cylinder. Okay, we'll discuss it. Okay, so before going to the cylinders, just look over here. What is this picture which is being given over here? This is the anesthesia machine, or it is also called as Boyle's machine. This Boyle's machine is divided into 3 parts. One is called as what? One is called as high pressure system, other is called as intermediate pressure system, and third is called as low pressure system. In high pressure system, we are having cylinders, yoke valve assembly, pressure gauge. In intermediate pressure system, we are having flow control valve, oxygen nitrous proportionating devices, and oxygen flush. By the way, oxygen flush delivers oxygen at a rate of how much, guys? Oxygen flush delivers oxygen at a rate of 35 to 75 liters per minute. Okay. In low pressure, you are having rotameter, vaporizer, and common gas outlet. Now, guys, first we'll discuss the most important part of the machine, that is called a cylinder. In cylinder, we'll discuss the color coding, we'll discuss the pin index system. What is a cylinder made up of? The most common material by which the cylinder is made up of is called as molybdenum. And these molybdenum cylinders are non-MRI compatible. You cannot take the cylinder into an MRI room, otherwise there will be a blast. Now, MRI compatible cylinders are made up of what, guys? MRI compatible cylinders are made up of titanium and aluminium. What are the sizes of cylinders, guys? Cylinders are smallest size cylinder, size A, largest is J, and most commonly we use size E cylinder. Coming to the, now how is the cylinder attached to the machine? Cylinder is attached to the machine with the help of an assembly which is called as yoke valve assembly. In the yoke valve assembly, there is a system that prevents wrong attachment of the cylinder, which is called as pin index system. Very, very important. Pin index system. Okay. But before going to pin index system, just a color coding, guys. Color coding. Oxygen, what is the color coding, guys? For oxygen cylinder, the color coding is what? It is the black body, white shoulders. Black body, white shoulders. For air cylinder, it is white body, black shoulders. Now, guys, air cylinder in some countries we use white body and black shoulders. For air cylinder in some countries we use gray body and black shoulders also. Okay. Nitrous is what? Nitrous means it's a complete blue cylinder. Complete blue cylinder. Entonox means what? It's a 50% of mixture of oxygen as well as nitrous. Okay. So Entonox is what? It is blue body, white shoulders. Carbon dioxide is gray color. Carbon dioxide is gray color cylinder. Now guys, sometimes they might be asking you about the color coding of the pipeline. Okay, apart from cylinders, there will be pipeline that would be attached to the diameter index safety system. This pipeline color is what? The pipeline color is basically the shoulder color of the cylinder. Oxygen pipeline color is what? The shoulder color, which is white in color. Oxygen is white in color. Air is black in color. Nitrous is blue in color. And vacuum, remember guys, vacuum starts with what alphabet? V. If you add a stroke to V, it looks like Y. So vacuum is yellow in color. Vacuum is yellow in color. Okay. Now guys, going to the what? Pin index system. Cylinders are attached to the machine with the help of yoke valve assembly. In the yoke valve assembly, there is a system that prevents the wrong attachment of the cylinder, that is called as pin index system. Now in the pin index system, we need to remember the pins are present on the machine and holes are present on the cylinder. Okay. Different pin index systems are given. 1, 2, 3, 4, 5, 6 and 7. 1, 2, 3, 4, 5, 6 and 7. So now what is the pin index system for air? Guys, if it is an air cylinder, it will fit into the first and fifth port. Okay. Oxygen 2, 5, yani second and fifth one. Nitrous 3 and 5. Entonox alphabets E, N, T, O, N, O, X is 7 alphabets, so 7. Carbon dioxide 1, 6 or 2, 6. Now how to remember this pin index system, guys? Remember, air starts with alphabet A. Okay? Alphabet A is the first alphabet. Remember guys, everyone just look over here. Before going to it, just look over here. 3 pin index system we can easily remember. Air, oxygen and nitrous. Why? Because remember, the second pin is common. What is the second pin? 5. We have to just remember the first pin. So how to remember the first pin? Air alphabet starts with A. A alphabet is the first one. So 1, 5. Okay? Oxygen, when you write O2, so it will be 2, 5. This 2 will come over here. 2, 5. Nitrous, when you are writing nitrous, N2O. N2O means what? 2 molecules of nitrogen and 1 molecule of oxygen all together. How many molecules? 3. So it will be 3, 5. Okay. Lastly, coming to this thing in the machine, which is called as vaporizer, guys. What is vaporizer? Vaporizer is the device that stores the liquid inhalational agent. The material by which vaporizer is made is called as copper material. Remember, desflurane requires a special vaporizer as it is having a low boiling point. And there are different colors given for the vaporizers. What are the different colors given for the vaporizers, guys? Remember, for halothane vaporizer, what is the color that we use? It is the red color for halothane. Whereas for sevoflurane, what is the color, guys? Sevo is, always remember, Sevo means Sevilla. Sevilla is Sevian dish, you know. Sevilla, it is yellow in color. So Sevo is yellow in color. Sevoflurane, and Sevilla is sweet. So Sevo is sweet odor also. Okay. I stands for isoflurane, that is, S stands for sevoflurane. I stands for isoflurane, which is purple in color, and D stands for what, guys? Desflurane, which is blue in color. This is desi jersey color is blue. So these are the color coding of vaporizer. Okay. Next question. A 65-year-old patient who's having COPD is being mechanically ventilated through a Mapleson circuit. Which circuit is most efficient for spontaneous ventilation? Come on, guys. For spontaneous ventilation, which is the Mapleson circuit, which is commonly used? Okay, A, B, C, D. I used to remember one line so that circuits I used to clearly remember. Just look over here. S, A, C, D. S, A, C, D. SA means what? SA means what? S means spontaneous, always it is Mapleson A. And C means what, guys? For controlled ventilation, always it is Mapleson D. So what's the answer over here? Spontaneous ventilation, it is Mapleson A circuit. Mapleson D is used for controlled ventilation. B and C तो आप देखते ही rule out करना है B and C. Why? Because remember, B and C are never used nowadays. These are obsolete circuit. Okay, so we were having two options, A and D. So SACD, if you remember, you can easily remember. So now regarding circuits, guys, Mapleson A circuit, it is also called as what? It is also called as McDull circuit, guys. This is also called as McDull circuit. This is the circuit of choice for what ventilation? For spontaneous ventilation, this is the circuit of choice. Now remember, when this circuit was introduced, there were no mechanical ventilators. It was just an experiment to introduce this circuit. Okay, so look over here. As we introduced the circuit, there were two pipes in the circuit. Okay, McDull introduced a system called as lag system, in which he gave two pipes into the circuit. The inner pipe was responsible for expiratory gases over here, and outer pipe was responsible for inspiratory gases. Okay, in the Mapleson circuit, basically you will be having two pipes. One is the inner pipe, other is the outer pipe. As the circuit was new, the inner was responsible for expiratory and outer was responsible for inspiratory. And there was a chance of rebreathing. Hence, what we gave is, in order to avoid rebreathing, we gave the fresh gas flow, which was equal to the minute ventilation volume. Okay. Now, that was Mapleson A. Next, Mapleson B and C came, we are not using. Then came Mapleson D. Mapleson D is a circuit of choice for what ventilation? For controlled ventilation. Nowadays, we are having mechanical ventilators, so we can use this. What is this circuit? Again, this was having some problem which was rectified by a guy called as Bain. R is silent. Bain. Hence, this circuit is also called as Bain circuit. Okay. What did Bain do? Bain also gave an inner piping. Okay. What inner? Now look over here. As he gave the inner piping, now he told that inner pipe should be for inspiratory and outer should be for expiratory. Outer should be for expiratory. This should be normal only, no guys. Inner means inspiratory, out means expiratory. This was rectified by Bain's. Okay, so remember Mapleson A circuit. If at all you guys like find it confusing that in Mapleson A circuit, which is inspiratory, which is expiratory, always remember Mapleson A was an experiment. That's why they did ulta pulta. Ulta pulta means what? Inner expiratory, outer inspiratory. Whereas D was a control, and nowadays it is commonly used. They did the normal thing, that is inner was inspiratory and outer was for expiratory. And in order to avoid rebreathing, fresh gas flow should be equal to how much, guys? 1.6 times a minute volume. Now, apart from that, we also remember Mapleson E is there and Mapleson F is there. Mapleson E is called as INI-TPs, which is again used for weaning the patient from mechanical ventilator. INI-TPs, or for patient transportation also you can use this. Otherwise, there is no use. Then there is Mapleson F circuit, which is also called as what? Jackson-Rees modification of type E circuit. Jackson-Rees modification. This Mapleson F circuit is the circuit of choice for controlled as well as spontaneous ventilation in home in pediatrics. Very, very important, guys. All these things. Okay. So this was regarding what, guys? This was regarding the breathing circuit. And now just one more point we need to remember, guys. The circuits that we discussed were the semi-open. This circuit, if at all you are using a closed circuit, say in semi-open circuit, Mapleson circuit, if you are using a closed circuit, then you have to use soda lime. Closed circuit is different from semi-open circuit. In closed circuit, the heart of closed circuit is what, guys? Soda lime. Soda lime is made up of what? 80% of calcium hydroxide, 16% of water, 3% of sodium hydroxide. Remember, the major component is calcium and the main component is what, guys? Sodium hydroxide. And 1 to 2% it is made up of silica. Silica is usually added to improve the hardness of the granules. Is it clear? That is regarding the soda lime. But remember, when you are using soda lime, 3 things should be avoided with soda lime. What 3 things should be avoided with soda lime, guys? I used to remember, whenever you are using soda lime, CT scan is avoided. C stands for what, guys? C stands for chloroform. Anyways, we are not using chloroform nowadays. T stands for trialine. Trialine again reacts with soda lime, leads to phosgene and dichloroacetylene. S stands for sevoflurane. SIVO should be avoided with soda lime. Why? Because SIVO in lower flows with soda lime, it can react and form a compound called as compound A or olefin, which is a nephrotoxic compound. Okay, so these are the agents avoided with soda lime in closed circuit. Apart from soda lime, there is one more carbon dioxide absorber used in closed circuit, that is barrelime. If you are using barrelime, 3 gases are avoided. What 3 gases? Dye gases. DIE. D stands for what, guys? Desflurane. I stands for isoflurane. E stands for enflurane. Why? Because if you use these 3 gases, they will react with barrelime and form a compound called as what? Form a carbon monoxide compound. And maximum carbon monoxide compound will be formed with desflurane. Desflurane. Okay, guys. Coming to the next question. Is it clear? Right. A 55-year-old patient collapses in the ward. He is unresponsive, apneic, and has no pulse. What is the next best step? So remember, guys, if a person collapses, what is the sequence that we need to do? If any person collapses, I'm not asking about the apnea or pulse. If you see any person collapses, the first step is scene safety. The second step is what, guys? Check for the response. If the person is not responding, you call for help. Next, you check for the pulse and breathing. In the question already, he is unresponsive. Pulse and breathing is not present. So directly answer is what, guys? Start compression. Start compression. So the order of sequence is what, guys? SCCS. S stands for scene safety. C, check response. C is call for help. One more C is what, guys? Check for the pulse as well as breathing. And last S is what? Start CPR. When you are starting CPR, you have to give high quality CPR with chest compressions. Now, guys, remember in the CPR, how are you starting? Basically, remember in this CPR, how are you starting? Are you starting the compressions? Are you first securing the airway? Are you first giving the breaths? Initially, we used to follow ABC, but now we used to follow CAB. C stands for what? Compression. A stands for airway. B stands for breathing. Compressions, airway, and breathing. Okay. So how many compressions should be given? Where should you give compressions? Always remember, lower third of the sternum, you have to place your hands and then give chest compressions. Now, what is the number of chest compressions that we need to give, guys? 100 to 120 compressions per minute should be given. What should be the depth of chest compressions, guys? It should be 5 to 6 centimeters or 2 to 2.4 inches. That should be the depth of chest compressions. Okay. Now, if it is an infant, what is the depth of chest compression, guys? In infant, it should be 1.5 inches or 4 centimeters. More than 1 year, if the child is more than 1 year, then 2 inches or 5 centimeters. 2 inches or 5 centimeters of depth should be achieved. Or basically, 1/3 of the anterior posterior diameter depth should be achieved in children. What is the ratio, guys? Ratio is 30:2. What is 30:2? 30:2 means what? In 1 minute, I need to finish 100 to 120 compressions. But I'm not giving continuously. I'll give 30 compressions, stop and give 2 rescue breaths. 30 compression, 2 rescue breaths. 30 compression, 2 rescue breaths. So in a minute, basically, I need to finish 4 cycles of 30:2 in order to achieve 100 to 120 compressions. Okay. And you have to allow a good chest recoil also. Okay. Now, what is the compression to ventilation ratio? Now, guys, compression to ventilation ratio, if there is one rescuer or if there are more than one rescuer. In adults, if there is one rescuer or more than one rescuer, always remember the compression to ventilation ratio is 30:2. 30:2. Okay. Now, whereas in pediatrics, what is the compression to ventilation ratio? If there is a single rescuer, it is 30:2. But if there are multiple rescuer in pediatrics, the compression to ventilation ratio should be 15:2. 15:2. Now imagine, guys, you are giving chest compression and your friend came for help and he put an advanced airway. Either he had put an LMA or either he had put an endotracheal tube. Then if he had put an LMA, will you give 30 compression and then stop and then give 2 rescue breaths? No. If advanced airway is present, then compression should be given continuously. But breath, how you are giving? Every 6 seconds, you are giving 1 rescue breath. Every 6 seconds, you are giving 1 rescue breath. That means in a minute, 60 seconds are there. So in a minute, 10 rescue breaths should be given in case of advanced airway. Okay? advanced airway is placed. Whereas in pediatrics, if advanced airway is placed, how many rescue breaths should be given? It should be 20 to 30 beats per minute. Whereas compression to ventilation ratio in newborn is how much, guys? It is 3:1. It is 3:1. Now guys, a question to you. When is this position used? Come on, be fast. When do you use this position? This position is used when a patient is conscious or unconscious. Come on. This position is used when a patient is having pulse. Okay? Patient is having pulse. Breathing is also there, but there is no response. Just in order to prevent the risk of aspiration, we tell the patient to lie in a recovery position. That is a lateral position. Lateral position. Okay. Conscious, no. Patient might be semi-conscious and you can go for this position. Okay. Response not there means what? Response not there means he's not conscious. Okay. But pulse and breathing are present. You have to keep the patient in the recovery position. So look over here, guys. If the patient is having pulseless ventricular tachycardia and after first shock, after 2 minutes, yani you have given shock, you have started CPR, and after 2 minutes you are checking the rhythm. Again, it is VT only. If it is first shock and the same rhythm persists, what you need to do? You need to repeat the defibrillation. Defibrillation. Remember, guys, after 2 shocks, you need to give what? You need to give adrenaline. Okay? And after 3 shocks, you need to give what? Amiodarone. Amiodarone, the first dose should be how much? 300 milligrams. And the second dose of amiodarone could be 150 milligrams. Is this thing clear, guys? Now, guys, this will happen. This happened with many of my staff. When my junior fails to resume compression immediately after defibrillation, we usually tell our junior, tumse na ho paega. Why? Because when we are new and all, we make mistakes. But remember, in CPR, the most important thing in ACLS, in the whole ACLS, it is compression. Never waste more than 10 seconds. Okay? Never waste more than 10 seconds. Never stop compression for more than 10 seconds. Okay? Now, guys, look over here. As we are talking about defibrillation, there are 2 kinds of mode, monophasic and biphasic. When we are talking about monophasic, remember in CPR, we will be giving asynchronous, not synchronous. Synchronous is given for tachycardias. Okay? With pulse. With pulseless tachycardia means we have to go for asynchronous. In monophasic, the shock that we give is 360 joules, monophasic. Whereas in biphasic, 120 to 200 joules should be given. Okay? And this is ventricular tachycardia. This is ventricular fibrillation, guys. Ventricular fibrillation. Okay? But if the patient is having asystole, if the patient is in asystole or non-shockable rhythm, then what you will do? If the patient is in non-shockable rhythm, no shock is given, give adrenaline as soon as possible. Give adrenaline or epinephrine as soon as possible. 1 milligram every 3 to 5 minutes you have to give. As soon as possible, you have to start adrenaline. And then you have to rule out 5 H's and 5 T's. Come on, guys. Who can tell me 5 H's and 5 T's? Be fast. 5 H's means what? H means what? You have to remember a hypovolemic patient. To remember 5 H's, hypovolemic patient. Once the patient is hypovolemia, he'll be having hypothermia. He'll be having, you have to remember, guys, hypovolemic patient. Hypovolemic patient will be hypothermic. He will be having hypoxia. He will be having hydrogen ion acidosis. And he'll also have hypo and hyperkalemia. That is 5 H's. 5 T's that we need to rule out are what? 5 H's we have already discussed. 5 T's, 2 T's related to the heart, 2 T's related to the lung. The 2 T's related to the heart are what, guys? Those are cardiac tamponade and coronary thrombosis. Okay. 2 T's related to the lungs are pulmonary thrombosis, okay, and tension pneumothorax. And last T is what, guys? Toxins. Any toxins can also. So these things are, you have to rule out during cardiac arrest. Now, one more thing in cardiac arrest is what, guys? This is the chain of survival. In the previous chain of survival, in the old chain of survival, we were having 5 things: recognition, immediate activation of CPR, rapid defibrillation, basic advanced emergency service, and advanced life support care. So look over here, post-arrest care. So look over here. Now the one more thing that is added in chain of survival is what, guys? It is recovery. Recovery is the component that is added in recent chain of survival. Now imagine you are giving CPR to the patient and now the patient has developed a pulse. If the patient is having pulse, what you will do? Chalo bhai, if the patient is having pulse, what you will do? And again, patient has, you have achieved ROSC. If you have achieved ROSC, what you need to do is your aim should be maintain the parameters. What parameters? Respiratory parameters, hemodynamics of the patient, and other parameters. So look over here. Once you have achieved ROSC, yani ke pulse is positive, then you have to manage the parameters: respiratory, hemodynamics, and airway. You have to look for the airway patency, whether the airway is patent or not. Respiratory parameters, what are the things you look for, guys? You look for the saturation. How much saturation, guys? Saturation should be 92 to 98%. In between 92 to 98%. PCO2, how much you should keep, guys? 35 to 45 mm of Hg. Okay, that is the respiratory parameters. In hemodynamics, the MAP should be how much? MAP should be more than or equal to 65 mm of Hg, whereas the systolic BP should be more than 90 mm of Hg. Okay, so we have achieved a ROSC. You have to maintain this and then get a 12 lead ECG. In 12 lead ECG, if there is a cardiac problem, please send the patient directly to the cath lab. But if at all there is no problem in the 12 lead ECG, then you need to assess the patient's response. If the patient is responding well, then just send the patient to ICU. But if still the patient is not responding, there is no cardiac issue but is not responding, then you have to go for a very important management, guys, that is called as TTM, target temperature monitoring. Just look over here, target temperature monitoring. So remember, if there is response, then just send the patient to ICU. If there is no response, you have to go for target temperature monitoring, where you have to keep the temperature of the patient between 32 to 36 degrees Celsius. When you keep the patient temperature at this, it will basically decrease the cerebral metabolic rate. That will help the brain to use less of oxygen. Okay, so 32 to 36 degrees of Celsius. This target temperature management should be done. Again, you have to send the patient for CT scan and other critical care management. This is regarding if you have achieved a ROSC. Okay. Now, guys, last tachycardia algorithm, guys. In tachycardia algorithm, remember, I'm not going into the details of it, guys. Remember, if the patient is having tachycardia, and if you see first, when a patient is having a tachycardia and when you have been called in the ICU, that patient is having a tachycardia, go and assess what kind of tachycardia is there, and then you go and then you have to assess whether the patient is having a stable or unstable tachycardia. Why? Because the management is different. Now, what do you mean by stable tachycardia and unstable tachycardia, guys? Unstable tachycardia means patient having features of Hasia features. Hasia means what? Yani ki patient is having a heart rate of 180 beats per minute. He's having tachycardia, and with that he is having hypotension. That means unstable tachycardia. Or is having altered mental status. Altered, A stands for altered mental status. Okay. S stands for what, guys? Signs of shock. Signs of shock. A stands for ischemic chest discomfort, and A stands for acute heart failure. Acute heart failure. If the patient is having tachycardia and he is having any of these features, Hasia features, he is unstable tachy. And treatment of choice for unstable tachy is always what, guys? You have to go for synchronized cardioversion. Very, very important. Treatment of choice for unstable tachycardia is what, guys? Synchronized cardioversion. Very, very important. Synchronized cardioversion. Okay, unstable. If the patient is having a stable tachycardia, then you have to go for VABC. ABC basically. Before going for ABC, if the patient is having stable means what? BP is fine and he is having tachycardia. First go for a vagal maneuver. If vagal maneuver does not work, then you go for ABC. ABC, A is the drug of choice for stable tachycardia, that is adenosine. Initially we go for 6 milligrams. If still not responding, we go for 12 milligrams. Then we can add beta blocker or calcium channel blocker also. In beta blocker, sotalol can be given. Okay, guys. Next. A 50-year-old patient develops fever, tachycardia, hypotension despite fluid and norepinephrine. Urine output is 20 ml per hour. Yani ki basically MAP is still low. Okay, after giving epinephrine, MAP is just 62. We have to increase the MAP of more than 65 mm of Hg. Okay, lactate is still high. That means patient is still having hypoperfusion. So normally for any shock-like conditions, the first thing that we give when the patient is having hypoperfusion or high lactate is what? We give fluids to the patient. If fluids are not working, then we add what, guys? Then we add norepinephrine. Okay? If still not there, then to the norepinephrine we add vasopressin. If still not improving, then we add adrenaline. Okay, so we have given fluids, we have given norepinephrine. What is the next line, guys? It is the vasopressin. Vasopressin. Again, adrenaline is the third line. If vasopressin fails, then you can go for adrenaline. But phenylephrine is an alpha agonist, we don't go for it. And milrinone is also not used over here. Okay, milrinone is also not used. Instead, you can also use, if at all the patient's cardiac output is low, you can add a dobutamine. You can add dobutamine if the patient's cardiac output is low. And also 200 milligrams of hydrocort can be added. Hydrocortisone can also be added. Okay. Guys, I told you, adrenaline is not the next option. Next additional should be what? Vasopressin. If vasopressin still not working, then add adrenaline. Okay. A 28-year-old woman develops circumoral numbness, dizziness, tinnitus during liposuction under infiltration anesthesia. These symptoms are most likely due to after receiving a infiltration anesthesia, patient develops tinnitus. If the patient was just having dizziness, it could be vasovagal or hypoglycemia, because in vasovagal hypoglycemia, patient might be having dizziness due to drop in the blood pressure. Okay, but remember, if it is not allergic also, guys. Why? Because in allergic condition, patient will be having rashes and all. It is the local anesthetic systemic toxicity. When you give local anesthetic systemic toxicity, you will get CNS symptoms such as tinnitus, such as circumoral numbness. That is the first sign of local anesthetic systemic toxicity. Okay, guys. Now, regarding local anesthetic, we have to discuss a few things, guys. What few things? What are the roots of local anesthetic? The chances of local anesthetic systemic toxicity is high when it is given through which route? The chances are high when it is given through IV route, followed by tracheal route, followed by intercostal route, followed by brachial plexus. Okay? The chances of local anesthetic toxicity is high when it is given through the IV route. Now, whenever you are giving a local anesthetic, in which form it is entering the nerve, guys? It is entering the nerve in a non-ionized form. The non-ionized form enters the nerve and it becomes ionized. This ionized form searches for the channels. What channels? Sodium channels, and blocks the voltage gated inactive sodium channels. Once these sodium channels are blocked, depolarization is blocked, and then action potential is also blocked. Okay, so in which form it is entering the nerve? It is entering in the non-ionized form, and ionized form blocks the sodium channel. Normally it will block most of the channels, but mainly the channels which are blocked are sodium channels. Now, what are the two forms of local anesthetic? Classification of local anesthetic, we have to remember. There is amino ester and amino amides. In amino ester, guys, you have to remember what are the amino esters. The examples: cocaine, procaine, benzocaine, tetracaine, proparacaine. Remember, guys, all amino ester, as the word of amino ester contains only one alphabet I. As the word amino ester contains one alphabet I, all the drugs of amino ester will have one I. Okay? So, one I. Cocaine, procaine, chlorprocaine, and tetracaine. So look over here, guys. In cocaine, regarding cocaine, what you need to remember, cocaine is the first used local anesthetic, and it is the only local anesthetic which produces potent vasoconstriction. Potent vasoconstriction that can increase the BP. Rest all of the local anesthetics are vasodilator. Okay. Next is what, guys? Next is amino amides. Remember, the other category of local anesthetic is amino amide. Amino amide, look at the spelling, guys. Look at the two highlighted I's over here. Yani in amino amide word, there are two I's. So all the drugs in amino amides will have two I's. Lignocaine, mepivacaine, bupivacaine, prilocaine, dibucaine, all are having two I's. The most commonly are used is what, guys? It is lignocaine. It is available everywhere. And most commonly used local anesthetic in spinal anesthesia is what, guys? It is bupivacaine. It is bupivacaine. Okay. Now, what else we need to remember, guys? To this local anesthetic, we can add something. To the local anesthetic, in order to increase the duration, I can add something that is called as an additive. What are the drugs which are used as an additive, guys? Opioids are used as an additive. Almost all opioids I will use as an additive, except what? Except of an opioid which is called as remifentanil. Remifentanil, I will avoid this opioid while I am giving spinal anesthesia. Remifentanil is avoided in spinal anesthesia. Why? Because remifentanil contains a neurotoxic preservative. Okay, remifentanil is metabolized by non-specific plasma esterases. Okay, now when you are adding opioid, it will increase the duration. But what is the side effect that patient might have with opioid? The most common side effect with opioid is what, guys? It is pruritus, that is itching and all. Apart from that, patient might have respiratory depression, nausea, vomiting also. Is this thing clear? In local anesthetic, what we need to remember is some local anesthetics are there which will cause allergic reaction. Now, what local anesthetic will cause allergic reaction? Those local anesthetic which are metabolized to a compound called as PABA. PABA is nothing but para-amino-benzoic acid. If you remember this letter PABA, you can remember this local anesthetic allergic reaction. Why? Because remember, the local anesthetic which are metabolized to PABA, that will cause allergic reaction. The local anesthetic starting with the alphabet P and B can cause allergic reaction. That is, procaine and benzocaine can cause allergic reaction. These two local anesthetic can cause allergic reaction. Okay, guys. Next. Select the correct pair of local anesthetic which is regarded as the longest acting and which is regarded as the most cardiotoxic local anesthetic. Come on, guys. What's the answer over here? Longest and the most cardiotoxic. For that, we need to remember the mnemonic I told you. Longest to shortest acting local anesthetic is what? Mnemonic is Delhi to Bombay loves Priyanka Chopra. Okay, right. Most of you have given the right answer. Option D. Okay, we'll go through the option D. Okay. Longest to shortest acting local anesthetic. The mnemonic is Delhi to Bombay loves Priyanka Chopra. D stands for dibucaine. T stands for tetracaine. B stands for bupivacaine. Okay. L stands for lignocaine, the most commonly used local anesthetic worldwide. P stands for procaine, the safest local anesthetic in malignant hyperthermia, procaine. C stands for chlorprocaine. So longest acting local anesthetic is what? We are having the longest dibucaine, but it is the most toxic also, hence we are not using it. Okay? We are only using it for the scoline apnea test. We use dibucaine number test, okay, for scoline apnea. Next, bupivacaine is the most commonly used in spinal and it is the most cardiotoxic local anesthetic. Most cardiotoxic local anesthetic. Is it clear? Delhi to Bombay loves Priyanka Chopra. So longest we got it and most cardiotoxic we got it, that is bupivacaine, okay. Now, regarding lignocaine, guys, lignocaine, 2 or 3 points of lignocaine we have to discuss. Lignocaine is most commonly asked also. Remember, with the spelling of lignocaine, you can remember the features. L of lignocaine means what, guys? L means it is the most commonly used local anesthetic worldwide. Local anesthetic, most commonly used worldwide. Okay. Most commonly used worldwide. Second most commonly used in spinal anesthesia. Second most commonly used in spinal anesthesia. Whereas I, remember the second alphabet of I of lignocaine. Lignocaine is the most commonly used in I. I stands for IVRA. It is the most commonly used in IVRA, intravenous regional anesthesia. We'll discuss what is IVRA. Okay? And G stands for what, guys? G stands for lignocaine produces or lignocaine causes garmi. Garmi is a Hindi word. English translation of garmi is what? Hyperthermic. So lignocaine causes malignant hyperthermia. G stands for garmi. So these 3 points you have to remember. And for a few more points of lignocaine is, what is the dose of lignocaine that we give? The plain dose of lignocaine, if you are giving plain lignocaine, it should be 4.5 mg per kg body weight. But if you are giving lignocaine with adrenaline, then you have to give the increased dose of 7 milligram per kg body weight. Okay. But if at all you give a high dose of lignocaine to the patient, the first, what will happen? Lignocaine will usually produce toxicity in which system? If you give a high dose, the first system will be affected is CNS, and the first sign of CNS toxicity is what I have already told you, that is perioral numbness. Perioral numbness followed by seizures, followed by tremors, followed by seizures and all. Okay, bupivacaine produces what? It is most commonly cardiovascular toxic. Okay, so if at all bupivacaine induced arrhythmias are there, we can give amiodarone. But anyways, if at all patient develops toxicity of any of these, lignocaine or bupivacaine, the treatment of choice remains what? It is intralipid solution. Intralipid 20% solution. Okay, that's regarding lignocaine. So as I told you, lignocaine is commonly used in IVRA. What is IVRA, guys? IVRA is intravenous regional anesthesia. Yani you are basically putting a basically putting a tonic way on the patient's hand, and you are giving local anesthetic over here. That local anesthetic will block only this part. It is not going up. Why? Because there is a tonic way which is not allowing the local anesthetic to spread up. That is called as intravenous regional anesthesia, also called as Bayer's block. In Bayer's block, what is the pressure of tonic way in the upper limb, guys? It is 50 plus systolic. It is 50 plus systolic blood pressure. Whereas in lower limb, what is the pressure, guys? 100 plus systolic BP. Why? Because lower limb pressure, muscles are high, will require much pressure to hold the blood volume. Okay. What is a drug that is contraindicated in IVRA? It is bupivacaine. You never give bupivacaine in IVRA. It is the most cardiotoxic, guys. Hence, we are not giving this. Okay. Coming to the next question. Okay. A 6-month-old receives prilocaine for local infiltration. After some times develops cyanosis unresponsive to oxygen therapy. Which is the most likely cause? Come on, first we'll rule out the options which are not there. Aspiration pneumonia, could it be the option? No, sir. Aspiration pneumonia could not be the answer over here. Why? Because remember, aspiration pneumonia will produce what? Respiratory distress. Will also produce cyanosis. But patient will respond to oxygen therapy. Okay? Bronchospasm. If the patient is developing bronchospasm, again, he will give response to oxygen therapy. Pulmonary embolism is very rare, guys. Very rarely seen in infants. So that could not be the reason. Remember what is being given in the question. Prilocaine is being given and patient develops cyanosis after prilocaine, unresponsive to oxygen therapy. Direct answer is what? Methemoglobinemia. Methemoglobinemia. Why does methemoglobinemia occur? Remember, guys, first of all, why is prilocaine given to a child? If a child is basically, if you want to put an IV cannula in the child, will he allow you to put an IV cannula easily? No. You put an cream, local anesthetic cream, that is called as EMLA cream, and then you apply. What does EMLA cream consist of, guys? Look over here. EMLA cream consists of lignocaine 2.5% and prilocaine 2.5%. We are not worried about the lignocaine, but if you give EMLA cream to neonates or less than 6-month-old, what will happen, guys? What will happen? That prilocaine which is given, it will get absorbed into the blood and it will get oxidized into, it will get metabolized into O-toluidine. O-toluidine. And what will this O-toluidine do? This O-toluidine usually goes into the hemoglobin and it will oxidize the ferrous form of hemoglobin to ferric form. Remember, the ferrous form of hemoglobin is having a good friendship towards oxygen. It usually carries oxygen. That's why tissues are well concentrated with oxygen in ferrous form. But what is prilocaine doing? It is oxidizing the ferrous form to ferric form. And this ferric form will cause what? It does not take oxygen. If it is not carrying oxygen, what will happen, guys? Tissues will be deprived of oxygen. Tissues will be deprived of oxygen. So remember, prilocaine is having toluidine. Okay? It is metabolized into toluidine, which oxidizes ferrous to ferric form. Okay? And patient will develop methemoglobinemia. If the patient develops methemoglobinemia, treatment is what, guys? You have to give IV methylene blue. IV methylene blue. Is this thing clear? Right. A 65-year-old man with diabetes and COPD is undergoing PAC before elective cholecystectomy. His ASA physical status is. What is the correct ASA status of this patient? ASA 1, 2, 3, 4. Come on, guys. What is the ASA status for this patient? Remember, patient is having COPD. First of all, PAC, when a patient comes for PAC, the last thing in the PAC is you give certificate to a patient, that is you are fit to undergo anesthesia. That is ASA certification. As the patient is having diabetes and COPD. COPD, they have not mentioned mild. When it is not mentioned any mild or something, you have to consider COPD is there, which usually comes under the category of moderate to severe disease. So any patient who is having moderate to severe disease comes under ASA class 3. ASA class 3. Okay. Now look over here. You know what is ASA classification in simple language? Just look over here, guys. ASA classification means class 1. Class 1 patient means I am healthy. Class 2 patient means what? I have a mild disease. He's a smoker or social drinker. He comes under class 2. Class 3 means what? I have a moderate to severe disease. Moderate to severe disease is there. Patient is having a high BMI, a low ejection fraction, moderate ejection fraction, sorry, not low, moderate ejection fraction. He comes under class 3. Class 4 means what? Basically, remember, class 1 is I am healthy. Class 2 is I have mild disease. Class 3 is I have moderate to severe disease. Class 4 is what? I am at risk of dying. Yani ki I am having a disease which is a threat to my life. Class 4. Class 5 means what, guys? I am about to die. Meaning what? I am having a systemic illness which is very severe, or multiple systemic illness, or basically moribund patient. Moribund patient. That is class 5. Class 6 means what? I am dead. Yani ki dead patient comes under ASA class 6 category. Okay. So we are discussing about what? ASA classification. As I already told you, patient free from systemic illnesses, class 1. Patient having mild to moderate, class 2. Class 3, moderate to severe. Okay. Uncontrolled alcohol dependence, moderate ejection fraction decrease. Class 4 means what? Patient having systemic illness which is life threatening. Life threatening systemic illness such as recent MI or ESRD. Moribund patient comes under class 5 and brain dead patient comes under class 6. Okay. Next, guys. During airway assessment of a 50-year-old man with obstructive sleep apnea, you perform a Mallampati test, but he is unable to fully open his mouth due to TMJ joint stiffness. Only hard palate is visible. What should be your interpretation and plan? Come on, guys. This patient is having which Mallampati class? You are able to see the hard palate only. Hard palate only means what, guys? It is Mallampati class 4. Okay. So these two are ruled out. Right. Now A and B, both are having class 4. Will you go for routine induction? No. Remember, it is an anticipated difficult airway. Patient came for PAC, you are anticipating. When you have anticipated difficult airway, you will prepare your advanced airway devices and go for it. So the right answer is what, guys? Mallampati class 4 patient is having an anticipated difficult airway. You are anticipating and you are going for the advanced airway devices. Now, guys, what are the other things apart from Mallampati which are used to anticipate difficult airway, guys? Come on. Other things used to anticipate difficult airway are Lemon classification, guys. Lemon is what? Everyone look over here. Lemon is look. L stands for look, E stands for evaluate, M stands for Mallampati, O stands for obstruction, neck, N stands for neck mobility. Look for facial features or any trauma. Okay, and then you have to give a score. Evaluate the 3-3-2 rule. 3-3-2 rule is what, guys? 3 fingers distance of interincisor, 3 finger distance of hyoid mental, and 2 finger distance of thyroid to hyoid. Mallampati classification and Mallampati scoring is given. O stands for obstruction and N stands for neck mobility. That is the Lemon scoring. Now, anyways, guys, we are discussing about what? Difficult airway. So when you are anticipating difficult airway, you prepare yourself. You prepare yourself with what, guys? You prepare yourself with that. This is what this set is called as difficult airway set. Difficult airway set. In difficult airway set, you keep different sizes of laryngoscope, different types of Goodell's airway, different types of LMAs, bougie you keep. All the things you keep. Meggle's forceps you are keeping. If the tube is not going, you can easily slide it through the forceps. So you are keeping all the things. That is class 3. Yani you are removing U. Okay? And class 4 is you are removing S. So remember, guys, push. Push. P stands for what? Tonsillar pillars. Totally visible. U stands for uvula. L stands for soft palate. And H stands for hard palate. Hard palate. Okay, that is class 1. All things are visible, class 1. Remove the tonsillar pillars, is become class 2. Tonsillar pillars will be partially visible in 2. But mostly what is visible? Uvula. But remember, uvula tip is not visible. Tip is not visible for uvula. S stands for soft palate. H stands for hard palate, fully visible. That is class 2. Class 3 means what? SH. In class 3, you might see base of uvula. You might see base of uvula. Again, you will see soft palate, hard palate. Okay? Class 4. Class 4, you will see what, guys? You won't see anything. You will see only hard palate. Then there is one more class called as class 0. Class 0 means what? All class 1 structures. Tonsilla, pilus, uvula, soft palate, hard palate, plus all class 1 plus tip of epiglottis. Tip of epiglottis visible. That is called as class 0. That's a very easy airway. Okay, guys. This is regarding what, guys? This is regarding the Mallampatti classification. Now, guys, just tell me. Anyways, guys, how's the patient's airway? The patient's airway is bad. Why? Because he's having he's a good cut chewer. Good cut chewer will have what, guys? This patient's airway will be restricted. Why? Because remember, any person who's a good cut chewer, he'll be having submucous fibrosis, so that he cannot open his mouth properly. Okay, and he'll be having a difficult airway. 70-year-old male with coronary artery disease is on aspirin and clopidogrel. Scheduled for TURP. What should be done pre-operatively? Come on, be fast. Kya karenge? Clopidogrel or aspirin? He is on. You should stop something and continue both the drugs. No, if you continue both the drugs, clopidogrel has to be stopped. Aspirin can be continued. Stop both the drugs? No, aspirin can be continued, and clopidogrel, if you are stopping, you have to stop 5 days prior surgery. So stop clopidogrel and continue aspirin. Stop clopidogrel and continue aspirin. Stop clopidogrel at least 8 days is mandatory, but if not 8 days, 5 days at least it should be there. Okay, so there are some medicines that should be continued and there are some medicines that should be stopped before surgery. Come on, guys. What are the medications that are continued and what are the medications that are stopped? Come on, again the scene is from 3 Idiots. ठीक है, जैसा चल रहा है वैसा चलने दो. कौन से medicines को बोलेंगे? All, remember guys, all active agents always approve. All those medicines starting with alphabet A can be given, such as anti-anginal drugs can be continued. Anti-anginal drugs can be continued. Anti-hypertensives can be continued, such as ACE inhibitors and ARBs. Next, anti-lipidemics can be continued. Dyslipidemic drugs can be continued. Atorvastatin, rosuvastatin. Anti-epileptics can be continued. Anti-thyroid medications can be continued without any problem. But what are the medications that are stopped, guys? The medications that are stopped are basically, remember guys, before posting the patient into the operation theater, will you tell the patient to go in his normal clothes, or will you tell him to remove the clothes and go in the hospital clothes into the operation theater? You will obviously tell him to go in the hospital clothes. So basically you need to remember, before surgery, what are the drugs that are stopped? My clothes of the patient. Yani ki patient clothes are stopped. Patient clothes means my clothes are stopped before surgery. Okay? What my clothes I am talking about, guys? My M stands for what? Monoamine oxidase inhibitors. Monoamine oxidase inhibitors, they are stopped 3 to 4 weeks prior surgery. 3 to 4 weeks prior surgery. C stands for what? Clothes. C stands for clopidogrel. It should be stopped 8 days prior surgery. L stands for lithium, which is a mood stabilizer drug. It has to be stopped 24 to 48 hours prior surgery. O stands for oral hypoglycemic drugs. Has to be stopped on the day of surgery. Okay? Why? Because patient is in a fasting state. You don't want more hypoglycemia. T stands for what? Tricyclic antidepressants. At least 3 weeks prior surgery, they have to be stopped. H stands for heparin. Heparin has to be stopped at least of 6 hours prior surgery. And S stands for smoking. Ideally, smoking should be stopped 3 to 6 weeks prior surgery. Most ideal is 6 weeks prior surgery. You have to stop smoking. Okay. These are the things which are continued and these are the things which are stopped. Apart from that, in PAC, we also have to remember the fasting guidelines. Fasting guidelines. Remember guys, apart from your mother, it is the anesthetist who usually asks the patient whether you have eaten food or not. But this time, not in the context that he wants the patient to eat. Mother wants the child to eat, but the anesthetist don't want his patient to eat. Why? Because if he eats and is posted for surgery, there are more chances that he might aspirate. So adults, remember guys, adults, if on solid food, how many hours of fasting is needed, guys? 8 hours of fasting is needed. Semi-solid food, 6 hours of fasting is needed. Liquid, 2 hours of fasting is needed. Whereas for water, guys, how many hours of fasting? Remember, liquid or water? Remember, liquid or water is the same. Okay. Liquid means any juices without pulp is liquid. Okay. In child, 2 hours of fasting is needed if he is on liquid. If he is on, remember in child 246 formula that we use. Okay. If he is on mother's milk, 4 hours of fasting, formula feed, 6 hours of fasting is needed. That's regarding the fasting guidelines. Okay, guys.